Welcome to the deep dive. Every day it feels like, you just can't escape it. News headlines full of anger, aggression, violence. It's everywhere.
It really is. Road rage, workplace issues,
hmm
it touches so many parts of life.
And it raises this huge question, doesn't it? Like, how do you tell the difference between, normal anger, maybe aggression that's actually needed to protect yourself, and then outright violence?
That's the core challenge. And that's exactly what we're digging into today. We're pulling key insights from, well, a really foundational chapter in psychiatric mental health nursing.
Okay.
The goal here is to equip you, the listener, with the knowledge and tools you need, how to manage these complex behaviors safely in a clinical setting, safe for patients, safe for staff.
Right. So covering assessment, interventions, the whole picture.
Exactly. Assessment, interventions, the ethical side, how it looks in the real world, really connecting this theory directly to your future nursing responsibilities.
Great. So let's start by unpacking these terms. Anger first. What are we actually talking about?
Okay, so anger is an emotional response. Completely normal, actually, usually to frustration, maybe feeling threatened or challenged.
So not inherently bad then.
Not at all.
Ah,
Sometimes it's positive. Think about channeling that energy into exercise or using it to motivate you to solve a problem. That's healthy anger expression.
right. Okay, then what about aggression? How's that different?
Aggression is more about the action. It's a behavior, could be verbal, could be physical, that results in an attack. Now, here's a key distinction.
hmm
Aggression isn't always inappropriate. Sometimes, it's necessary for self-protection.
Ah, okay, that makes sense. So where does violence fit in?
Violence is the line. It's always an objectionable act. Always. We're talking intentional use of force that results in, or crucially could result in, injury to someone else. No gray area there.
Got it. Violence always bad. Aggression sometimes necessary. Anger normal emotion.
You've got it.
So this is clearly a major issue in healthcare settings then. How common is it, really?
Well, it's a huge concern. CDC data from back in 2014 showed nearly 60,000 violence-related injuries in just that year. And nurses. Nurses are often the targets.
Because of the direct contact.
Exactly. Most direct patient contact. Now, it can happen anywhere in a hospital, but emergency rooms, that's where it's most frequent. But we also see a lot in psychiatric units, geriatric settings, ICUs.
Can you give us an example, something that really brings home the reality for nurses?
Yeah, unfortunately, there are many. There was a case in Texas, an outpatient surgery center, where a nurse was tragically stabbed by a patient's son. Or in Maine, a psychiatric hospital, one patient injured a nurse's face with a chair, another stabbed a nurse with a pen.
Wow.
These aren't abstract risks, they're real dangers. Another nurse in Texas was attacked with a clipboard in the ER. It happens.
That's, yeah, incredibly sobering. It makes you wonder, what are the underlying factors? Why do some individuals become aggressive or violent?
That's the million-dollar question, isn't it? Often, there's comorbidity involved. We see strong links between anger and aggression and conditions like PTSD, post-traumatic stress disorder, and also substance use disorders.
Okay.
Research even shows patients with bipolar disorder can really struggle with anger, even when their main symptoms are in remission.
And it's not just mental health, right? You mentioned physical impacts.
Absolutely. Anger and hostility aren't just feelings. They have real physical consequences. They're known risk factors for hypertension, cardiovascular disease. We're talking heart attacks, strokes.
Serious stuff.
Very. And in older adults, expressed anger has even been linked to metabolic syndrome. So the mind-body connection is incredibly strong here.
So delving deeper into the why, what about biology, genetics, the brain itself?
Both play a huge role. Biologically, yeah, there might be a genetic predisposition for some people towards irritability or anger, and then there's the brain structure and function. Well, neurological conditions, think brain tumors, Alzheimer's, temporal lobe epilepsy, even traumatic brain injury, can all cause personality changes that sometimes include increased aggression or violence.
And specific brain areas. I remember learning about the limbic system.
Exactly. The limbic system is key. It's our emotional control center.
Yeah.
You've got the amygdala in there, the hippocampus.
Right, the amygdala is like the threat detector.
Precisely. It evaluates experiences, flags threats, triggers that fight or flight response. And studies, they've suggested a link between aggression and changes in amygdala volume. Some aggressive men show lower volume, for instance.
Interesting. And the hippocampus, memory.
Yep, vital for forming new memories. And it's connected to the amygdala.
Yeah.
There's even a fascinating sort of theory that engaging in aggressive behavior might actually lead to new cell formation in the hippocampus.
Wait, so getting angry could make you angrier in the future, like a cycle.
Potentially, yeah.
Yeah.
It suggests this feedback loop where the behavior reinforces the underlying neural pathways. It's complex, but that's the idea.
Wow. Okay. And the prefrontal cortex, the part that helps us make decisions.
Crucial. That's our executive function hub. It helps us weigh consequences, understand social rules, suppress impulses. When that system isn't working properly, aggression can result.
Like in certain personality disorders.
Exactly. For example, studies have shown less gray matter in the prefrontal cortex of individuals with antisocial personality disorder, which impacts their impulse control.
So brain structure, what about brain chemistry, neurotransmitters?
Absolutely vital. Serotonin is a big one. It can inhibit or stimulate aggression depending on the context and receptor type. Dopamine plays a role, especially in reward-seeking behavior, which can sometimes manifest aggressively. And GABA, the main inhibitory neurotransmitter, generally reduces aggressiveness. It's all about balance.
A really complex biological picture. Okay, shifting gears a bit. What about the psychological side? How do we learn these responses?
Well, historically, you had thinkers like Freud talking about the conflict between our basic drives, like sexual needs and societal rules. Later, Menninger suggested that our struggle for control is fundamental. When we feel that control is threatened, it can lead to trauma. And from there, anger, aggression, maybe violence.
So a feeling of losing control is a trigger.
It can be a powerful one. Then you have the behaviorist, like Skinner. They saw emotions, anger included, as learned responses. Something happens in the environment, we react.
Okay.
But it gets more nuanced with cognitive theories, like Beck's appraisal model. It's not just the event itself, but how we think about it. If you perceive something as a threat, maybe not physical, but a threat to your values, your self-esteem, and then you have thoughts like, they can't treat me this way, that's when frustration can really escalate into anger.
So my interpretation makes all the difference.
Absolutely. Someone less predisposed might face the same frustrating situation, say, a long wait at a clinic, but think, wow, they're really busy today, and maybe proactively ask for an update rather than getting angry.
Right. And what about learning by watching others, social learning?
That's Bandura's big contribution. His research showed how children, especially, learn aggressive behaviors by observing others, parents, peers, media figures, and seeing if that behavior gets rewarded or punished.
Like violence on TV.
Exactly. Often on TV, the aggressor doesn't face negative consequences, which can inadvertently teach that aggression works. And, a more common, less extreme form we see everywhere is bullying. That's learned aggressive behavior intended to harm.
That connection between observation and learning is powerful. You mentioned culture earlier.
Yeah.
Can we touch on that again? Specific cultural syndromes.
Yes, definitely. A good example is Hwabyung, sometimes called the anger syndrome. It's primarily seen in middle-aged or older Korean women.
How does it manifest?
It often involves suppressed anger, feelings of emptiness, but also significant physical symptoms, headaches, palpitations, digestive issues. There was a case example, Cho Hyun-ja, a 42-year-old woman. She felt intense anger towards her husband and mother-in-law, but couldn't express it directly.
So the anger comes out physically.
In a way, yes.
Yeah.
In some cultures, expressing psychological distress might carry stigma, while physical symptoms are more acceptable ways to signal something's wrong. So for someone like Cho Hyun-ja, treatment has to be holistic. You need coping strategies, maybe lifestyle changes, cognitive behavioral therapy to address the anger and anxiety, sometimes even things like pastoral counseling or support groups.
That really highlights why cultural competence is so crucial for nurses. Okay, so we had this really complex picture, biology, psychology, culture. How do nurses actually start to identify and plan for potential anger and aggression in a clinical setting?
It all starts with assessment. That's step one in the nursing process, and it's absolutely critical here. Nurses need to be sharp observers.
What are they looking for?
Observable signs of escalating anger. Things like, is the patient making more demands? Are they more irritable? Frowning constantly? Pacing? Clenching their fists? Changes in speech, maybe louder, maybe faster, maybe suddenly very quiet? Eye contact? Changes in intense staring or complete avoidance? Any change from their usual behavior is a potential red flag.
Okay, changes from baseline. What's the single biggest warning sign?
The literature points strongly to hyperactivity, pacing, restlessness. Those are key predictors that things might escalate towards violence.
Restlessness. Got it. What else? Are there other specific signs, like from that box 27.1 in the text?
Yes, absolutely. Besides hyperactivity, look for increasing anxiety and tension, a clenched jaw, a really rigid posture, that fixed, tense facial expression. Maybe they're mumbling to themselves, shortness of breath, sweating, rapid pulse, those physiological signs.
Okay.
Also, Verbal abuse is a clear sign. Stone silence can be just as concerning. Any recent acts of violence, obviously, if they're intoxicated with alcohol or drugs, if they have a weapon or something that could be used as one, and sometimes just uncharacteristic isolation can precede an outburst.
And the environment matters too, right?
Definitely. Things like overcrowding on a unit, maybe staff inexperience, staff who are provocative or too controlling, poor limit setting, arbitrarily taking away privileges. These are called milieu characteristics, and they can definitely contribute to violence potential.
So, lots to observe. What about the patient's history?
Crucial. A history of aggression or violence is the single best predictor of future violence. You need to know that.
Yeah.
And identifying their specific triggers what sets them off. That's vital information for planning care.
This sounds very focused on the patient. What about the nurse's role? Their own feelings?
That brings us to self-assessment. It's absolutely essential. You, as the nurse, need to be aware of your own strengths, your needs, your concerns, your vulnerabilities. Why? Because if you're not, your response to an angry patient might be impulsive, driven by your own fear or frustration, not by a calm therapeutic plan.
So, checking my own reactions for this.
Yes.
Yeah.
Your word choice, your tone of voice, your body language. Are you standing rigidly? Are you avoiding eye contact out of fear? All of that communicates something to the patient and can either escalate or de-escalate the situation.
Makes sense. You can't calm someone else if you're not calm yourself. This connects to the bigger issue of workplace violence too, doesn't it?
It really does. It's been a problem in healthcare for a long, long time. The American Nurses Association, in their Code of Ethics, really stresses the need for civility, kindness, respect, creating that safe, ethical environment. And this ties into trauma-informed care as well, recognizing that many disruptive patients have their own histories of trauma, violence, victimization. These past experiences can make it really hard for them to self-soothe, making them more vulnerable to feeling threatened by things like seclusion or restraints.
So understanding their trauma helps us respond better.
Exactly. Careful assessment and actually asking the patient, what makes you upset? How would you like us to help you when you feel that way? That kind of collaboration has been shown to actually reduce the use of restrictive interventions like restraints.
Involving the patient is key then. Okay, so boiling it down, what are the absolute must-ask questions to assess risk?
Okay, key risk identification questions. Number 1, history of violence, best predictor. Number 2, are delusions present, especially paranoid ones? 3, are they hyperactive? 4, impulsive. 5, irritable.
Got it. History, delusions, hyperactivity, impulsivity, irritability.
Yes. And then the critical follow-up. Does the patient have a wish or intent to harm someone? Do they have a specific plan? Do they have the means available to carry out that plan? Those intent, plan, means questions are crucial for assessing immediate danger.
Okay. Any demographic factors to keep in mind?
That some demographic factors show correlations, though we need to be careful not to stereotype. Statistically, risk is higher for males ages 14-24, lower socioeconomic status, inadequate support systems, maybe a history of prison time. And remember, aggression often happens when nurses are setting limits, especially if the patient lacks good coping skills.
Okay, so that's a thorough assessment. How does this translate into a formal nursing plan?
Right, so based on all that assessment data, you formulate nursing diagnoses. Things like risk for other-directed violence, or maybe risk for self-directed violence, or perhaps ineffective coping if they're overwhelmed or using maladaptive strategies. Stress overload, impaired impulse control. These are common ones.
And then you set goals, like in table 27.1.
Exactly. Outcomes identification. These need to be clear, measurable. So, for example, an outcome might be patient will identify triggers for anger by date, or patient will identify 2 alternative behaviors to aggression by discharge, or maybe patient will maintain self-control without supervision. Things like expressing feelings verbally, not violating personal space, using new coping skills learned in therapy.
Specific and measurable.
Yes. And then the planning phase pulls it all together.
Yeah.
It requires that solid assessment, knowing the patient's history, their triggers, their current coping skills, and importantly, their willingness to actually learn and practice nonviolent ways of managing anger.
Okay, assessment, diagnosis, outcomes, planning. Now let's get into the interventions. How do nurses actually step in? Let's start with communication, psychosocial approaches.
Ideally, you intervene before things escalate significantly. The foundation is building trust. Even brief, non-threatening interactions can help establish rapport.
How do you approach someone who's already angry?
Carefully. You need to project calm control, be non-threatening, and maintain a caring manner, even if, honestly, you're feeling scared inside. Personal space is huge here. Patients at risk for violence often need more space than usual. Stay about 1 foot farther away than they could reach with a kick or swing, and always make sure you have an escape route. Don't let the patient get between you and the door.
Smart. What about verbal abuse?
It's tough, but try not to take it personally. Don't fire back with your own insults. And crucially, don't just end the conversation because they're being abusive. That can sometimes escalate things. Stay with them. Maybe set a limit like, I want to help you, but I can't listen when you're shouting. But stay engaged if safe.
Okay. And if their anger is clearly rising?
Their ability to process information goes down, so you need to adjust your communication. Speak slowly. Use short, simple sentences. Keep your voice low and calm. Never, ever yell back.
What kind of things should you say?
Use open-ended statements that encourage them to talk, like, you seem really upset about something, or reflect what you think they're feeling. You sound as though you feel people are treating you unfairly. Avoid challenging statements like, what's your problem? Offer clear, simple options. Would you like to go to your room for a bit? Or maybe the quiet room? Giving choices can reduce that feeling of powerlessness that often fuels aggression.
And where should these interactions happen?
Ideally, in a quiet place, but one where other staff can still see you or easily intervene if needed. And before you even start talking, do a quick scan and remove potential weapons from the immediate area. Anything heavy, sharp, be aware.
Makes sense. Safety first. Are there specific staff safety rules, like beyond personal space?
Yes, there are about 6 basic considerations usually taught. 1. Avoid dangling jewelry, scarves, anything that could be grabbed. 2. Ensure you have backup available other staff nearby, aware of the situation. But usually, only one person should do the talking to avoid confusion. 3. Know the layout of the area, exits, obstacles. 4. Don't stand directly in front of the patient or block the doorway. Stand off to the side. 5. Give feedback on their behavior. You seem very upset right now. 6. Avoid confrontation. Don't get into arguments or power struggles.
Okay, avoid dangling things, have backup, know the space, stand aside, give feedback, avoid arguing.
Got it. So these are all part of de-escalation techniques, right? Can you summarize the main principles, like from box 27.2?
Absolutely. De-escalation boils down to a few core ideas. First, maintain the patient's self-esteem and dignity. Don't humiliate them. Second, maintain your own calmness and the patient's calmness as much as possible. Third, assess the situation and the patient, what's going on. What are the stressors? Respond early, don't wait for things to blow up.
Use that calm, clear tone. Invest the time needed. Don't rush. Be honest. Figure out what the patient actually needs in that moment. Identify goals clearly. Don't invade their personal space. Don't argue. Give those clear options we talked about. Be genuine and empathetic. Be assertive. State your needs or limits clearly but not aggressive. And always, always maintain personal safety.
That's a really solid framework. Okay, communication is key. What about medications? When do they come into play?
Medications or pharmacological interventions are often used alongside these psychosocial strategies, especially for acute symptoms. We're usually talking about PRN or as-needed medications to help manage anxiety or agitation quickly.
What kinds of meds, like in Table 27.2?
Yes, common ones include anti-anxiety agents, benzodiazepines like lorazepam, alprazolam, diazepam. They were pretty quickly. Then you have first-generation antipsychotics like haloperidol, often called Haldol or clearpromazine, and second-generation antipsychotics like risperidone, olanzapine, ziprasidone.
How are they given?
Various ways, depending on the situation and the specific drug. Orally, PO, intramuscular injection, IM. Sometimes IV, sublingually, SL, orally disintegrating tablets, ODTs, which dissolve quickly, even inhaled forms like loxapine.
Are there risks to watch out for?
Always. With haloperidol, for example, there's a risk of neuroleptic malignant syndrome, a serious side effect. Benzodiazepines can cause sedation and need caution in patients with liver issues. Inhaled loxapine has a specific warning about potentially fatal bronchospasm. IM olanzapine shouldn't be given close together with IM lorazepam because of risks. Sometimes combinations are used, like haloperidol and lorazepam together, maybe with an anticholinergic like benztropine or diphenhydramine to reduce side effects like muscle stiffness.
So lots for the nurse to consider.
Definitely. Your role is to assess if the PRN is appropriate, administer it safely, monitor for effects and side effects, and importantly, educate the patient about the medication, even if they're agitated. Letting them know what you're giving and why is still important.
Right. That's for acute situations. What about long-term medication for ongoing aggression issues?
For chronic aggression, the medication strategy usually targets the underlying psychiatric disorder that might be contributing. So the medications used depend on the diagnosis.
Like what? What classes are in Table 27.3?
You might see SSRIs, selective serotonin reuptake inhibitors, commonly used for depression, anxiety, sometimes personality disorders. Lithium is often used for bipolar disorder, but also sometimes for aggression linked to intellectual disability or conduct disorder. Anticonvulsants like carbamazepine or valproate are used not just for seizures, but also for mood stabilization in bipolar, schizophrenia, or personality disorders.
Others too.
Yes, gabapentin sometimes for anxiety. Benzodiazepines might be used for anxiety components, but you have to be really careful about dependence and abuse potential. Second-generation antipsychotics like clozapine or risperidone are often used for psychosis or mania, which can involve aggression. Beta blockers, surprisingly, sometimes help with aggression related to brain injury or dementia, and psychostimulants might be used if the aggression is linked to untreated ADHD.
Each with their own things to watch for, I assume.
Absolutely. Lithium needs regular blood level monitoring. Anticonvulsants can have drug interactions. Clozapine requires strict blood monitoring because of a risk called a granulocytosis. Beta blockers aren't suitable for everyone, like those with asthma. So long-term management requires careful selection and ongoing monitoring.
Okay, medication is one tool. What about education? Health teaching?
Hugely important. The nurse is a vital educator and role model. You can teach patients much healthier ways to express anger. You can teach coping mechanisms, deep breathing, mindfulness, distraction techniques. You can teach de-escalation skills they can use on themselves, self-soothing strategies.
Like helping them recognize their own warning signs.
Exactly. Helping patients identify their personal triggers and their early warning signs of rising anger is key. We even use something called the do-over method sometimes. If a patient responds inappropriately, you might gently coach them. Okay, that didn't work so well. How about we try that again? What could you say differently next time? It reinforces learning in the moment.
That sounds really practical.
It can be. And there's growing interest in things like forgiveness and compassion training, too, as ways to manage anger, especially for generally healthy individuals.
And this all happens best as part of a team, right?
Oh, absolutely. Teamwork and safety go hand in hand. For patients with behavioral challenges, a consistent multidisciplinary approach is crucial. Everyone needs to be on the same page with the care plan. The environment matters too, reducing excessive noise or stimulation, providing options for timeouts, maybe in a quiet room or even a specialized multisensory room, if available, sometimes called snozolin rooms. Having predictable schedules displayed can also help reduce anxiety.
What about patients who might be manipulative?
That's a real challenge, especially with some personality disorders like antisocial personality. They might try to split staff, create chaos, or provoke incidents. It means staff need to be not only focused on the patient during an escalation, but also maintain awareness of the whole environment, what other patients are doing, and communicate clearly with each other to avoid being manipulated.
Okay, so we've covered communication, meds, education, teamwork. But what happens when none of that works? When a patient is in immediate danger?
That's when we have to consider the most restrictive interventions, seclusion and restraints. And I have to stress this, these are last resorts.
Only when absolutely necessary.
Only when the patient poses an imminent risk of harm to themselves or others, and only when less restrictive methods have failed or are inappropriate. They are never, ever to be used for punishment, or just because it's convenient for staff.
Can you define them clearly?
Sure. Seclusion is involuntarily confining a person alone in a room or area where they are physically prevented from leaving. Restraint is any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of the patient to move their arms, legs, body, or head freely.
Are there times you absolutely should not use these? Contraindications.
Yes, definitely. They're contraindicated if the patient has an unstable medical or psychiatric condition that requires close monitoring, think severe COPD, a spinal injury, seizure disorders, pregnancy. Also, for patients in delirium or dementia, seclusion might make them worse because of the lack of stimulation. And they're generally not used for patients who are overtly suicidal and need constant observation, or those needing monitoring for drug reactions or overdose.
And there are strict rules around using them, legally and ethically.
Very strict. You need an order from a licensed independent practitioner, a doctor, nurse practitioner, PA. In an emergency, you can apply them first, but you have to get the order immediately after. Once someone is in restraints or seclusion, there are requirements for continuous observation or very frequent regular assessments, checking their physical needs, safety, level of awareness, vital signs, hydration, toileting, nutrition, comfort. It's intensive monitoring.
How is it actually done, the process of applying restraints?
It needs to be an organized team approach. One person leads, usually a nurse. Everyone on the team knows their specific role, which limb they're responsible for example. The leader is the only one who talks to the patient, explaining calmly what's happening and why. The goal is to apply them quickly and safely with minimal struggle to ensure everyone's safety.
Then getting them out. Reintegration.
That needs to be gradual. As the patient regains control, you might remove one restraint at a time, assessing their ability to follow commands and manage their behavior with less restriction. The goal is to get them back to their regular unit activities safely.
What about after the event? For the staff.
Debriefing is critical. Immediately after any restraint or seclusion episode, the staff involved need to have a critical incident debriefing.
What happens in that?
They talk about what happened. Could it have been prevented? Was the response effective? How are staff members feeling? Were there injuries? What documentation is needed? Are there educational needs identified? What could be done differently next time? It's essential for quality improvement and for processing the event emotionally.
And documenting everything is obviously key too.
Paramount. You need meticulous documentation. The behaviors leading up to it, all the less restrictive interventions tried, and the patient's response, exactly what happened during the escalation and intervention, all the observations during the restraint or seclusion period, and the process of reintegration. The NIC, the Nursing Interventions Classification, has a specific intervention called Anger Control Assistance, box 27.4 in the text, that reinforces many of these principles.
Okay, that covers the what and how of seclusion and restraint. Now, how do interventions differ based on the type of patient? One size doesn't fit all, right?
Not at all. Let's break it down. First, think about patients who usually cope well, but are just overwhelmed by being in the hospital. Maybe they're in pain, scared, feeling a loss of control.
Like in general medical units.
Exactly. Interventions here focus on helping them tap into their usual coping mechanisms, collaborate with them, validate their distress. This must be incredibly frustrating, scary for you. Sometimes a simple apology if something went wrong can help. Sympathize.
Can you give an example, like that Rachel vignette?
Yes, Rachel, the 41-year-old with vascular disease, facing amputation, refusing surgery, getting really angry. Her nurse didn't just dismiss her anger. She acknowledged Rachel's fear, her feeling of being railroaded. She validated those feelings. Box 27.5 lists feelings like being discounted, embarrassed, ignored, inadequate, out of control, threaten these often precipitate anger. By empathizing and negotiating for more time, the nurse helped Rachel calm down, process her grief, and eventually consider alternatives. Empathy was key.
That's powerful. Okay, what about patients who start with marginal coping skills? The ones who maybe use anger to get their way?
Right? These patients need a different approach. They might use anger or intimidation when their usual, perhaps less mature coping skills fail, or to feel in control. They often blame others. Here, interventions might involve proactively meeting their needs to reduce baseline anxiety, anticipating needs for pain meds, comfort items. Reducing ambiguity is huge, clear, concrete communication.
Like the example you mentioned earlier.
Yeah, saying, I can't order Vicodin, but I will talk to the MP about your pain options. Or using withdrawal protocols if substance use is a factor. Distraction can work simple activities. Predictable routines help. If they externalize blame, sometimes a gentle challenge might engage them in learning new ways.
What if they're verbally abusive?
With persistent verbal abuse, you might need to set firm limits. Maybe say, I'm leaving now, I'll be back in 15 minutes when things are calmer. Or complete necessary tasks with minimal interaction, then later, when they're calm, reinforce that you'll engage more when they communicate respectfully. Use scheduled contacts rather than responding only to demands. Remember the 21-year-old man in the car accident vignette?
The one yelling at nurses?
Yes. The nurse directly but non-punitively challenged him. Is this working for you? It got his attention. It wasn't aggressive, just direct. And that opened the door to teaching him other ways to get staff attention.
Direct but non-punitive. Okay. How about inpatient psychiatric settings?
Here, aggression often correlates more with the patient's individual characteristics, history of violence, impulsivity, than just their diagnosis. But the situation matters too. Feeling vulnerable, powerless due to hospital routines, having needs unmet, these can trigger anger. Early intervention is vital. Teaching patients to recognize their own early anger signs and use strategies before they escalate.
Like the 19-year-old quadriplegic man.
Exactly. He had a history of drug misuse, used anger and intimidation to cope, and felt suicidal. The key was identifying his triggers, feeling unheard, feeling controlled by staff rules. The nurse worked with him to role-play alternative responses, things he could say instead of cussing people out. They even made a behavioral contract. Giving him tools to feel heard and gain personal control reduced his anger and suicidal thoughts. It empowered him.
Empowering the patient. Great. Lastly, patients with cognitive deficits, dementia, delirium, brain injury.
This requires a very different approach. Reality orientation, telling them, no, your husband died years ago, often backfires. It increases fear and education.
So what do you do instead?
Focus on the environment. Make it simple, predictable, comfortable. Decrease sensory overload. Maintain routines. Use familiar objects. A rocking chair can be soothing. Use sedating meds very cautiously because they can worsen confusion or increase fall risk. Look for catastrophic reactions, sudden intense outbursts. Try to identify the antecedent, the trigger.
Like the 81-year-old woman with Alzheimer's.
Yes, she got agitated during morning care. The trigger wasn't the care itself, but the caregiver moving back and forth between her and her roommate. The solution: one caregiver stayed consistently with her. Agitation resolved. Simple change, big impact.
Finding the trigger is key. What about validation therapy?
That's a really valuable technique here. Instead of correcting their disorientation, you reflect back the feeling behind their words. The example was Mrs. Green wanting to go home to her babies. Instead of saying, your children are grown, the nurse says, Mrs. Green, you miss your children. It must feel lonely here sometimes.
So you validate the emotion, not necessarily the fact.
Exactly. You acknowledge their reality, their feelings. It helps them feel understood and safe. It builds rapport. And sometimes, paradoxically, feeling understood allows them to calm down and maybe even reorient themselves as they talk about their memories. It's truly patient-centered.
That's fascinating. Okay, we've covered assessment, planning, interventions for different groups. How do we wrap this up with evaluation?
Evaluation is the final step, and it's ongoing. For patients with anger or aggression potential, you're constantly checking. Are the interventions working? Are we meeting those outcomes we set? Do we need to revise the plan? It closes the loop.
And it feeds back into that debriefing process after an incident, too.
Absolutely. The evaluation includes those critical debriefing questions for staff. Could we have prevented it? Was our response good? How are we feeling? Do we need more training? What can we do better? And importantly, discussing the incident with the patient afterwards, when they're calm, is also part of evaluation, helping them learn from it and plan alternatives for the future.
Wow. We have really covered a lot today. A true deep dive into managing anger, aggression, and violence in psychiatric nursing. It's such an intricate balance, isn't it? Understanding the roots, but also having those practical, safe, and empathetic interventions ready.
It really is. And it goes beyond just managing difficult situations. It's about advocating for truly holistic, patient-centered care. It's about creating a safe environment for everyone, patients and staff. Understanding those patient cues, setting appropriate goals, using effective interventions, these are vital skills across every single nursing setting. And always remember, past behavior is the best predictor, and your own self-awareness as a nurse is crucial.
And remembering that violence is always unacceptable, but there are so many effective ways to de-escalate before it gets to that point.
Precisely. And interventions have to be tailored to coping skills, cognitive status, potential for violence, and those last resorts, seclusion and restraint, always used judiciously, humanely, and with strict protocols.
It really highlights the responsibility, but also the potential for nurses to make a huge positive impact. That connection between the theory, the real-world challenges, and your role is so clear.
Absolutely. So, as you, our listeners, continue building your knowledge base from texts like Varkarolus, remember you're not just learning facts. You're building empathy, critical thinking, and the skills to provide compassionate, effective care in this vital field.
Well said. Until next time, keep asking those big questions and keep digging deeper.